Well, hello and welcome to our virtual clinic on diabetic macular edema with Ranjan Rajendran and Adam Muppani from Moorfields Eye Clinics. We are doing a recording today as we had some technical issues before, and Ranjan has kindly given us some time again to go through his slides, which is fantastic. So thanks very much. So Ranjan, welcome. And it's nice to have you back. So thank you for your time today.
Thanks very much, Colin. It's a pleasure. I understand fully technical problems, so thank you.
Brilliant. So I shall leave it up to you then. So we'll go straight in. So I'll put myself on mute and we'll listen to what you have to say. So thanks.
Colin. There we go. So hopefully, patients, Colin, you can see my screen. I'm Ranj Rajendran. I work at Moorfields Eye Hospital. I'm a medical retina consultant. And Colin very kindly organised some meetings where we could discuss conditions that patients may have and want to know a bit more detail. And so I'm going to talk about diabetic macular edema today. This, I'll explain, is swelling at the back of the eye as a result of diabetes. As I said, I work at Moorfields. We're very fortunate through NICE. We have a good range of approved treatments for use in diabetic macular edema. I work both at Moorfields and the Institute of Ophthalmology, UCL, doing clinical work as well as research into the retinal diseases and imaging. And there's so much that we have been learning and still to learn, so very important that we continue to see lots of patients. So as everyone well knows, last year was a very difficult year. First lockdown, we were quite concerned about patients with diabetes, all patients, staff coming into clinics. Those of you who've been to clinics before 2020 will remember busy waiting rooms, not much social distancing. And so we really restricted the treatment to pretty immediately sight-threatening conditions such as wet macular degeneration, and where possible we deferred or extended intervals for other conditions. The second and third lockdown, we were able to do injections. We did virtual assessments, so where before patients would have come in to see the optometrist, the doctor, and the tech. This time, to minimize sort of exposure time, we would just check vision, do an OCT scan, and then the decision would be made based on the scan. We'll talk about OCT scans and why they're important. As well, during that time, second and third lockdown, we tried to extend the interval between injections for diabetic macular edema, again, to reduce visits and exposure time for patients. We have increased virtual clinics dramatically. These are clinics where you would go in, have your vision checked, have a colour photograph and an OCT scan typically, and then go home. So that's a much shorter visit, and those images would then be reported within a few days, and you'd get a letter explaining what was seen, whether things are stable. Clinic services now have pretty much returned, so there are face-to-face traditional clinics, although, as I said, more virtual clinics means there's a slightly different mix in the way patients are seen in clinics. Very important that if you do have any eye problems, I know a lot of patients and people are concerned about going to hospitals, or they don't want to kind of put any strain on the services, but absolutely, if you have a problem with your vision, if there's new blurred vision, new distortion, anything you're worried about, you must get in contact to your eye clinic. Your GP, optometrists are seeing patients as well in the community in the high street. So don't wait at home. In almost all cases, it's much better to find out what's going on early, so that we can document that and then start treatment early if it's needed. Fully agree with everyone who's experienced the difficulties of lockdown. It's been very difficult to maintain activity, regular exercise, going out and about, for walks, for runs, whatever. And while we've been told to stay at home, it's very tempting to deviate from our previously healthy diet. So like everyone, Adam and I have found we've put on some weight, and we're desperately trying to, both of us are now cycling as much as we can, walking and trying to get that healthy diet. So we've been also trying to learn about how to stay healthy. Moorfields is looking, we're very aware that we deferred some appointments, and so we are actively looking with a study to see if that would have had an effect on patients' outcomes. So you may be approached if you're attending the clinic to take part in the study to follow you over the next 18 months or so. Very happy to talk with the Macular Society and Colin about diabetic macular edema. I think their information, their website, their booklets, particularly we have in the clinic, are fantastic. And yeah, I was talking to Colin earlier. Sometimes the clinics are pretty busy, and out of 15 things I really want to say to a patient, I might remember to do 10 of them. And so that's where the booklets come in so handily in terms of diabetes, talking about the condition, what we can do in terms of controlling blood sugar, blood pressure, talking to the GP about HbA1c. All of these things are really important, what to expect from the treatments, when treatment is given, when it isn't given, does it need to be given straight away. All of these things are questions that we would like to answer, and practically sometimes it doesn't happen. And so that's where the booklets come in very handy. Please have a look at the Macular Society website. So diabetic macular edema, as I've said, it's a complication of a systemic disease. So it's one of a number of things that can happen with diabetes that's been there for a little while. And the two reasons for the vision being affected broadly are diabetic retinopathy, so that's more of the peripheral retina, where you get abnormal blood vessels, and diabetic maculopathy, so that's specifically involving the central part, which we use to read with. And if you get diabetic macular edema, that's the blood vessels becoming a bit leaky and then fluid accumulating in the central part. So that can make your vision blurry. The maculopathy is a slower progressing thing, so it's not something that develops overnight or needs treatment immediately. So we do generally have a little bit of time compared with other conditions. I'll talk about a little bit about the background, diabetes, the available treatments, our general kind of management plans, a little bit about practical points, although Adam Muppani after me will cover that more, and then a little bit about future treatments. So why is diabetic retinopathy, diabetic maculopathy important? Well, diabetes is increasing generally worldwide. It's a very large problem coming, and so the number of people with complications from diabetes will also increase. So over the next 15 years or so, there's projected to be a 50% increase, and so services will be needed to deliver the treatments and to see the patients. So we may need new ways of working, and we don't think that there's going to be a doubling in the number of doctors, for example. So new ways of working. Diabetes in general, the prevalence of diabetic macular edema is about 6-7%. In newly diagnosed diabetes, presence of any diabetic retinopathy is about 10%. And sometimes some people may have had diabetes for some time before the diagnosis. It's can present in different ways. Some people may feel a little bit tired, and so it's difficult to attribute that directly to a specific cause. So there's sometimes a little bit of a delay. in the UK, we have a multi-ethnic population, and in some of the population, Afro-Caribbeans and South Asians, there's more diabetic macular edema proportionately. So the eye is basically a camera. As you probably know, the front part of the eye to the left of this picture here is the focusing apparatus, so the cornea, and the lens, similar to you have in a camera, focuses the light onto the back of the eye. In a camera, you'd have the sensor or the film. In you'd have the retina, which is a very thin layer of tissue. It's about 250 microns thick, so a quarter of a millimeter thick. And it contains 130 million cells all networked. So it's a complicated thing, and it works very hard, and uses a lot of oxygen. In fact, more oxygen per gram than any other tissue in your body. So it's very dependent on its blood supply, and when things go awry, then you can quite quickly have problems with the vision. This is some of the imaging that we are doing now. Most of the sites have wide field color imaging, and that enables us to see not just the center, which we did with traditional imaging, but also the periphery. And that's important. As I said, diabetic macular edema affects the central part, whereas retinopathy can affect any part of the retina. So very useful to have these images that we can show patients and show them what's happening in the inside of their eye, and talk about what things are like at the moment and have they progressed. And so the detail is very good, so we can zoom in and look at particular parts of the retina. So we want to zoom in and focus and look at the macular and the central part, the fovea, which we use for reading, or we want to look at the optic disc, which connects the eye to the nerve that goes to the brain. So it's very useful to have these images as a record, so that we can compare sequentially over visits, because one of the things that leads to treatment decisions, should we treat or not, is whether things have progressed. So here's a slide of an eye that's got a little bit of pigment, so maybe an Asian or Afro-Caribbean retina. And we can see that there's some small hemorrhages and abnormal blood vessels here. And then in the center, we can see these glistening yellow spots, which are leakages of fluid. So there's some retinopathy and maculopathy here. And very important, as I said, to compare with the previous image to see if things have progressed. Important to know that if we improve our diabetes, blood pressure, cholesterol, the retinopathy may improve. So it can go both ways. Here's the image I showed you on the left, looking at the macula, the central part of the retina in cross-section. And here you can see at the bottom all the layers of cells, which I'd be happy to talk to you about. A lot of research going on into how things work back there, and why the retina is able to work so hard for 70 years with this high oxygen demand and its very high metabolic rate. So this is a section of the retina, and then the OCT scan on the right side of your picture shows us that in cross-section. So then again, this is the fovea, the central part of the retina that we use for reading, and it shows us the layers here. And so that's a scan that can be done very easily. It's just a light scan, like a photograph, just takes a couple of seconds, and we try to do it on most patients at most visits when everything is working well. We can see here in the left picture, there's some thickening. So the retina is thickened, there's some cystic spaces in the center. If we look at the color picture, we can see those glistening leakages, and that's leakage from a blood vessel. Exudates, we call them, and they're a form of lipid that collects in the retina. And then on the right, after treatment with some anti-VEGF injection in this case, we can see that the foveal contour, that curve, that dip, has been restored. So with treatment, the anatomy can be restored, and hopefully the vision can improve. So that's diabetic macular edema, the fluid in the left. There's also very important to look at the retinal blood vessels, as we can see here. So this is a different kind of OCT scan that shows us the retinal blood vessels, and these can be affected in diabetes. The small capillaries can be blocked, and the central zone, the foveolar-vascular zone, can become irregular. We can see these dark areas where capillaries have become occluded. So as well as the fluid buildup, some of the small capillaries can be damaged. And so there's two things that can affect the central part of the vision there. This is a little bit about how this happens. So with long-term diabetes, blood sugars can affect the small blood vessels, and they can become leaky. You can get fluid leaking out, it's called edema, and that leaks out into the central part of the retina. And if some lipid leaks out, that can be deposited as an exudate. And we can see that on the OCT scan here. They're thickening centrally, and these fluids fill space, macular edema. So there are many things that may be contributing to that. One of the major things is the lining of the blood vessels becomes leaky, and fluid can leak out. In diabetes, VEGF, which is vascular endothelial growth factor, can be produced, and that can cause leakiness. And so that's one of the main treatments to block that pathway. There are many others. There is inflammation, and there are other drugs that are available and are being developed. So that's just a little bit about what the high blood sugars can do to the retina. This is a large slide here looking at around the world what could be the prevalence of all of these individual components of diabetes. And we're interested in diabetic macular edema, and these are the main risk factors. So if you've had diabetes, the duration of it can lead to an increased risk of diabetic macular edema. The HbA1c, and that's the long-term blood sugar that takes an average of the blood sugars over about 3 months. If that's been high, that can lead to an increased risk of diabetic macular edema. Blood pressure, again, can lead to an increased risk of diabetic macular edema, and lipids. So if there's high cholesterol, that can also be linked with diabetic macular edema. So we talked about what the lockdown effect has had on us. So probably anything like me, we're not supposed to go out, or less exercise. We're sitting in front of the TV, and maybe diet has not been quite so good. So all of these things have not helped, and so we're Adam and I and everyone else is trying to get back on track. So blood sugars being high, if we control blood sugars, there's a reduced risk of progression of diabetic retinopathy and maculopathy. Blood pressure, if that's well controlled, we reduce the risk of diabetic retinopathy progression. Cholesterol, from the field and ACCORD studies, that may be a risk factor for maculopathy. Other things where we talked about diabetes can affect several systems, the heart, the kidneys. If the kidneys are affected, that can also affect the diabetes in the eye. They all go together. I think there was a question from Geraldine and Colin from the Macular Society. Someone asked whether if you control the blood sugars, can that affect the diabetic retinopathy? It can, if the blood sugar is brought very sharply under control. So if it's been very high for a long time, and then there's a very sharp reduction following starting of therapy, initially the diabetic retinopathy can worsen. But in the long term, as we've seen from other studies, it's much better to have good control of the blood sugar in order to reduce the risk of progression of diabetic retinopathy. HbA1c, we talked about it. Why is it important? In terms of the eye, if you have very good blood sugar control, that may help to the treatments and diabetic macular edema to be better controlled. So it's definitely worth, in the longer term, getting control of the blood sugar with your GP or diabetologist. So diabetic macular edema, NHS therapy, we're very fortunate. We have available a range of therapies that can be used. I'll talk a little bit later about when they're used. It's not necessarily to use them immediately that anything is spotted in the retina. There's a threshold where they may be effective, and I'll come on to that a little bit later. The main treatments for center-involving diabetic macular edema, which is affecting the vision, is anti-VEGF. So we have two licensed alternatives, ranibizumab and aflibercept. There are also steroid treatment. We mentioned that sometimes inflammation is a component of diabetic macular edema, and so there are steroid implants. One is dexamethasone and the other is fluocinolone. These are long-lasting, slow-release implants. They have also, along with any treatments, have some side effects, so we just need to be a bit wary, a bit cautious about which ones we use and when. Laser is a very good treatment that we use for many years, and it's still used for non-center involving diabetic macular edema. And combined with anti-VEGF, it may reduce the frequency of injections over the longer term from some large studies. So laser, if the center is not involved, if it's more peripheral, we might use laser to try and slow down progression of diabetic macular edema. It's unlikely to improve vision, but it may slow it down and stop it getting worse over the longer term. So here we go. If somebody was untreated, they might lose 6 letters over 2 years, whereas if they had some laser treatment, there's a 12% of people would improve their vision. A bit more in the other studies, so the DRCR-NET laser arm. If we use laser, you could gain 4 letters at 2 years, and 31% of people improve by 2 lines or 10 letters. Intravitreal anti-VEGF, this has become the mainstay of center-involving diabetic macular edema. You can see somebody's had a few injections, and you can see gradually that foveal contour is restored, that dip in the center, and the thickness of the retina has come down from 424 microns to 350 microns. So that's what we measure when we're looking at those OCT scans. This is the image I showed you before. I think this is after a few anti-VEGF injections. In this case, the vision improved, and the foveal contour, that curvature, was restored. So many of the large studies were done by an organization called the DRCR-NET, and they looked at, in protocol I, change in vision over 5 years with ranibizumab. They looked at patients who had laser injections straight away versus patients who had ranibizumab and laser a bit later. And they found that it's probably best to start the injections and then come back a bit later and add the laser in. This is the number of injections, and overall, in the first year, you might have 8 to 9 injections. In the second year, 2 or 3. Third year, 1 or 2. Fourth and fifth years, none, or maybe 1 injection. So something gets modified with that course of treatment. It's very important to explain that it is a course of treatment. Obviously, we would all like to have something that we would just be given the treatment or give a treatment and that would fix things. Unfortunately, it's not quite like that, but we can take heart if we can get through the first 1 or 2 years. The number of injections required would be less. Protocol T, that's a study by DRCR-NET. They covered a comparison between 3 anti-VEGF agents, aflibercept and ranibizumab, which we use in the NHS, and bevacizumab. And they found that in people with good vision, there was a good benefit over 2 years. So these patients on the left who had reasonably good vision, so kind of 6'9" to 6'12", and they gained about 7 letters. in patients who had the worst vision, so thicker maculars, as we see on the scan, those patients gained more, so about 17 letters. So that's the comparison. They found overall at 2 years there wasn't much difference between Lucentis and Eylea, so ranibizumab and aflibercept. So here we go. All the drugs improved vision over 2 years with a reduced number of injections. If the vision is good, there's a smaller benefit. If the vision is not so good, if you've got a thick macula, there's a good chance of improving vision and stabilizing diabetic maculopathy. If the vision's worse, and the macula is thicker, you may do a bit better with aflibercept. We use these drugs at Moorfields, and it's very important to look at how they do, and so that's a main thing that we try to do. Here we can see over a year, patients gained 6 to 7 letters, so that's comparable with some of the studies, Restore, and a little bit behind the DRC-ARNET studies. Although the study here that I'm showing at Moorfields was done right at the beginning when we started the treatment, so there was a slightly different population. Number of injections, we were similar, maybe a little bit behind the DRC-ARNET studies at 7 injections in the first year. Aflibercept, that's the other drug, over a year, 100 eyes treated, and there was about a 10-letter gain in vision and a reduction in the thickness of the macula centrally of about 128, and that's with 7 injections. What about if you have good vision but have some macular edema? They have looked at that. The main issue is that we do a lot of screening, which is great. The diabetic retinopathy screening program is fantastic, and everyone who has diabetes should be offered to have photographic screening. It means that we pick things up early, which is fantastic. That doesn't mean we need to treat everyone who have early diabetic retinopathy or maculopathy. There may be a stage where we can observe things, and if things are improving, maybe the HbA1c has improved, that's fine, we can monitor it. If they're staying the same, we can also monitor it. If there's progression, then that's more likely that we want to get on and intervene. OCT scans are readily available in optometrists, and we have increased access to anti-VEGF. So we do see increasingly patients who have very good vision, but have some diabetic macular edema. So they found that if you have center-involving diabetic macular edema and the vision is better than 6/9, so quite good, it would be safe and good to observe for a little while to see what's happening. If things worsen, so if the vision drops, if the thickness of the macula increases, then that will be a trigger to start the anti-VEGF therapy if the central part is involved. If the center isn't involved, then we can use the macular laser, and sometimes we use those two in combination. So here's some images over a period of about 2 years. The vision is pretty good. It's sort of the almost the bottom line of the chart, maybe 1 or 2 lines up from the bottom. And it shows that the thickness remained fairly stable. And so in this case, we didn't need to do intervention, we just need to monitor. And hopefully with improving things, diet, HbA1c, blood pressure, cholesterol, the retinopathy and maculopathy can improve. So in patients with vision loss due to center-involving diabetic macular edema, we can use anti-VEGF treatments. In patients with center-involving diabetic macular edema who have good vision, it's okay to observe initially, so you'd be monitored with repeat scans. And if the vision patient notices or the scan thickens, if things are progressing, then we could offer anti-VEGF. Some patients are not keen on having injections to the eye, and so we could consider macular laser for the non-center involving part. If the center isn't involved and it's just the more peripheral macula, then we could offer macular laser treatment. And it's important to note 40% of patients with diabetic macular edema may have good vision, so there would be quite a few patients that observation is a good initial strategy. And the risk of progression is quite low from non-center to center involving macular edema, about 14% of people per year. So the steroids, so they're slow release preparations, dexamethasone and Iluvien. Dexamethasone is bioerodible, which means it dissolves slowly over time, perhaps 3 or 4 months, and Iluvien is non-bioerodible, so the implant remains in the eye. And these are the reasons why we use steroids. There is some inflammation, and steroids reduce inflammation. They may block white cells moving in to the wrong place and tighten up the leakiness of the vessels. This is the MEAD study, and it showed on the right there that there is a benefit, the dexamethasone implant, about 6 letters gained. So similar to some of the VEGF that we saw. And if we look at the bottom, a similar reduction in the thickness of about 120 microns. As I said earlier, we just need to be a little bit wary. In some people, steroids can put up the pressure in the eye, the intraocular pressure, and usually that settles down as the drug dissolves. But if it's a little bit higher, we may want to give some eye drops to control the pressure, and very rarely we might need to do a procedure, very rarely. In the UK, we use steroid implants if the patient has had cataract surgery, so the lens taken out and a synthetic lens implanted. In other places where steroids can be used in people who have their natural lens in the eye, there's an increased risk of cataract. The FAME studies looked at the Iluvien implant, which is the slow release implant, and it found that in chronic, so diabetic macular edema, which is present for more than 3 years, there was a benefit, whereas in non-chronic, so if you've had diabetic macular edema for less than 3 years, there's not a benefit of the treatment. Again, fluocinolone is a steroid implant, so there is a risk of raised intraocular pressure. So we want to see patients regularly, or if they can't see us for any reason, they should try and get their pressure checked in the eye. So anti-VEGF is first-line therapy. We very much hope to stabilize visual acuity and macular edema, good chance of improving it. Side effects are very small. You may need repeated injections, as I said, with a decrease in frequency over a few years. Steroid therapy is second-line therapy, so if the diabetic macular edema has not responded to anti-VEGF therapy and they've had the natural lens removed from the eye and replaced with a synthetic lens, then we could offer steroid therapy. There is a risk of rise in eye pressure, and so that would need regular monitoring. We've said diabetes, HbA1c control is very important, blood pressure control very important, and lipid control is important. 95% chance that vision will not deteriorate over 5 years with the injections, 50 to 60% chance of a 2-line on the chart improvement, maybe a 30 to 40% chance of a 3-line improvement on the chart. This obviously is a course of treatment we've talked about over a few years. Particularly the first year is a little bit intensive, regular injections monthly, perhaps 7 or 8 injections in the first year. But then after that, the requirement drops, and so less visits to clinic. The other, so we've talked about maculopathy. Retinopathy is where blood vessels behave abnormally, and occasionally you can get new blood vessels growing, and that can affect vision if they bleed, and so we need to monitor for that, and the treatment for that is laser treatment in the periphery. Risk of infection with any injection, if we were to do 4,000 injections, one person could get a bleed or an infection, People have wondered whether the treatments could be associated with cardiovascular risk. That's very hard to attribute to a particular treatment. If you have diabetes and complications of diabetes, they can affect the heart and the kidney, and so the risk of having a cardiac event or a stroke is higher in somebody who has diabetes with complications. And so it's not possible to say that's directly due to a treatment. Large studies were not powered to look at that. And overall, really, we want to give treatment to try and help vision. We're generally a bit cautious if there's been a recent cardiovascular event, but that's a discussion you would have with your doctor in the clinic. We've talked about HbA1c. We're very fortunate at Moorfields to have a diabetic nurse specialist. There are many things I've talked about and probably gone on a bit longer than I should have, but that's sometimes difficult to discuss all of those points in the clinic. So it's very important to have support from our diabetic nurse specialist, your GP, to monitor blood sugar, blood pressure, and cholesterol. We tend to do OCTs at most visits. At the beginning, we may do a fluorescein angiogram or an OCTA like the one I showed you in the beginning to show us what the retinal capillaries look like, because that may also affect vision. Some people have some scarring on the surface of the retina, and that again can affect vision. So it's important to know about other things that may one stop or two stops. So that means most of the decisions about treatment, about retinopathy, are made in the clinic, and then you go for your injections to the injection clinic, which is very effective at delivering injections. We work very closely with the optometrists, technicians who do the imaging and the visions, and nurse injectors who do most of the injections. We deliver a lot of injections, and so the way we're able to see the patients and deliver the treatments is with all of our colleagues. We have a checklist where we ask people if they've had any recent events. If patients with diabetes can be younger, and so if they are pregnant or planning to become pregnant, we avoid anti-VEGF injections. If the eye can occasionally be painful or red, usually that settles down quickly after an injection. But if there's any worsening vision, worsening redness, worsening pain, we must attend the emergency department. It's always open, particularly the first week after an injection. It's a course of treatment, so as I was talking about, it may be 7 or 8 injections in the first year, so it might be better to have the initial 3 or 5 injections, and then if you're planning to go away after that. It's important that we do that initial loading phase so that we can see if there's an effect of the treatment. Other things, it's important to keep a monitor on the vision and the OCT scan, and also to treat things like dry eye blepharitis, which can make your eye uncomfortable after an injection. So you could discuss that with your doctor. We use iodine, the injections as the best thing to reduce the risk of an infection. If that's irritating, it can be washed out at the end of the procedure. So the future, we want to deliver more imaging and closer to patients' homes. That's the way I think things will move. So we have better imaging technology with wide field views and OCT scans. We need to get that closer to patients rather than bring them all the way into a clinic or a hospital. More research into diabetes affects the eye. It may also affect the heart or the brain, and we need to try and link up the care so that it's managed holistically as a patient rather than as an eye or a heart. The clinics can be busy, and so it can be difficult to have that communication, but we need to work on getting better at that between the specialities. And how do they together? Yeah, good. There are many trials, clinical trials, 104 studies going, and 231 completed. These are future treatments, mostly intravitreal injections, some sustained release anti-VEGF, so hopefully a longer interval between the injections, some light therapy and some gene therapy. Those are all in development phases. Newer forms of laser are becoming available, more gentle, and extended interval between injections. So ongoing studies. Port delivery, people are looking at research that may reduce the number of infections. We definitely need to do more research, which we are involved with. So hopefully we've had these treatments which have really improved outcomes, and I'm very optimistic over the next 5-10 years there'll be even more treatments and monitoring so that we can avoid progression if at all possible. So sorry to go on so long, there's a lot to cover. Very grateful to Colin for reorganising his support worker, Joe from the Macular Society and the Macular Society. I have fantastic information, and it's always something I try to advise patients to have a look at. Thank you, Colin.
Brilliant. Thanks, Brad. That was really interesting. As you say, loads and loads of information there. Lots and lots. I know people are looking forward to seeing this. So thanks very much again. We're getting on to Adam Muppani, who's your colleague. He's a consultant nurse from Moorfields, and he's going to talk about the injections and injection clinics and things. So Adam, welcome, and over to you.
Thank you so much, Colin, and thank you, Mr. Rajendran, who is gone first. So what I thought I could share with the members of the Macular Society, our valuable patients, is to talk about your clinic appointment and the recent changes due to COVID-19, and also touch a little bit about the experience in the injection suite service. So my name is Adam Muppani. I'm a nurse consultant, and it's a pleasure to be invited to speak to this platform. So Moorfields in the 19th century, Moorfields now, and Moorfields when we moved to our next location in St. Pancras. So service innovation due to the crisis, the practicalities and impact on patient care. So I'm gonna use the Moorfields case study, the way how we have responded to the crisis, and how that is impacting on patient pathways, your future clinic appointments, and the support that is readily available from us in helping you to make sure that your appointment goes as smooth as possible. So the challenge for ophthalmology is that prior to the pandemic, there was 60% increase in the overall caseload for patients with diabetic retinopathy and age-related macular degeneration. So we see that this is diabetes, it's a pandemic on top of another pandemic. And in 2016, the Royal College of Ophthalmologists highlighted the desperate need to address capacity crisis in the eye clinic department. So there were 20 patients per month facing severe vision loss whilst waiting for their appointment. So this is worrying. And in 2018, the Royal College of Ophthalmology carried out a workforce census, and it highlighted the growing gap between demand workforce. And there was a shortfall of 230 consultants. So guidance on restarting our medical retina services. So these are the recommendations and the opportunities for us to try to catch up with the growing backlog. So extended working patterns, imaging hubs. So you hear a lot more about those digital hubs and how they look like in real practice. Virtual review, what does that mean? And joint working with community optometrists or primary care providers. So the guidance on restarting the services, we think about the problem in the background. So there's 30 to 80% pre-COVID capacity issues. Then we've got the backlog, and then there's the real and perceived safety considerations. So restoration of services does require a detailed review, redesign of the whole pathway to ensure a safe environment for patients, their families, their carers, and staff. So social distancing issues, self-sufficiency, all those things that would help to make sure that the environment is as safe to you and also to our staff. These are the new pathways in the digital hubs. So I'm pleased to share on behalf of the Medical Retina Service a lot of collaborative efforts, collective efforts in establishing these digital hubs. So when you attend your future digital hubs, some of you may have already been in the pathway. What we mean exactly by digital hubs is the use of technology, use of digital technology to try to do a more efficient way of coming up with a diagnosis without the need to go through a face-to-face clinic appointment. So on arrival at Moorfields, we have got a pool of volunteers at our main reception who are there to welcome you, who are there to support you and to guide you in the relevant departments. There's also Moorfields members of staff who will give you personal protective equipment, such as a surgical mask, to ensure that you are protected, your family members are protected, and we are also protected. So you come in at the reception, you get assistance to go to your destination. So when you arrive in our digital hubs, so at the main Steroid branch, the digital hubs are located on the second floor. So on arrival at the second floor, there's clear signage, and there's also support to ensure that your appointment goes as smooth as possible. You check in with the receptionist and you are asked to take a seat. And one of our very highly trained technicians, they will call you, check your details, correct patient, correct date of birth, address, similar to what we used to have when you go to the general clinics. This time around, you will notice that there's no one holding patient files or those thick files. It's a paperless environment. It's an electronic medical record system that we use. And this allows us to be more efficient and to be more practical in terms of how we respond to the growing capacity demands. Then your history is taken. We want to know more about symptoms. We also want to know if there's any change with your medical history, and also change with your eyesight. And your medication, very important to bring this, and recent letters or communication with your GPs or any other service providers. We check your vision, we check your intraocular pressure, and then we dilate the pupil so that we can take pictures of the back of the eye. So as I say, we use the electronic medical records, and the software we use is called Open Eyes. Now, for patients living with diabetes, I'm pleased to say that technology has also risen beyond expectation, because we've got some form of digital innovation equipment, such as wide field imaging, which enable us to have a clear, detailed understanding of the peripheral retina. Mr. Rajendran is leading on that. And then once you have your images, once you have your scans, once you've had all those baseline tests recorded, you will then be asked to go home. The technicians may also give you some additional information about what to expect on your next appointment and how results are cascaded or communicated to you. We review those tests in some form of virtual review, and that data or diagnostic baseline tests is reviewed in real time. So for patients with high risk diabetic eye disease, we're able to offer them urgent treatment. We call urgently, and you are advised of your next appointment. For those patients who present or on the scans show that there's diabetic macular edema, they will also receive a telephone call from one of our administrators offering them the appointment for an injection. Some of our patients, they may require additional investigations. So we may ask you to come back to the face-to-face clinic where we may need to do some additional investigations, such as the gold standard fundus fluorescein angiogram procedure or yellow dye test, so that we are able to establish whether there's any form of macular ischemia or not in terms of oxygen supply to the back of the eye. So the outcome from the digital hubs visit, patients either got the injection appointment if they fulfill the criteria for intravitreal injections. They may also need laser appointment for those patients who present with high-risk proliferative diabetic retinopathy. And we are also privileged to have a diabetes specialist nurse within the department. So we should be able to triage those patients who need disease education, educational support, disease counseling, or those who might have general fears or concerns about anything. And then for those patients who may not need treatment, who are still kind of like borderline treatment, or they may require some extra monitoring, we will monitor them in the digital hubs. So there's also, again, a very clear pathway. And also just to mention that in the digital hubs, the technicians that you see, they are highly trained. We've also established online courses during the pandemic to ensure that our technicians, they have the educational and expertise in carrying out those diagnostic tests. On this slide, it shows patient care as in supported by the diabetes specialist nurse, Sister Beckway, who is one of our diabetes specialist nurses here at Moorfields. So patients living with diabetes who may need lifestyle advice, medical advice, or psychological support and some form of reassurance, they can receive that support through telephone consultation. Becky, who is our diabetes specialist nurse, she has a list and she can put appointments in place. She's very, very helpful. She should be able to support anyone who needs that support. And we also see the importance of this service in providing information about diabetic eye disease, information about what goes on in the clinic, and also the importance of attending eye clinics. This graph shows the amount of patients that Beck has seen from the 17th of March to 31st of August last year. As you can see from the screen, from the data for a telephone consultation on that time period, she conducted a lot of patients. She also offered consultations. She was also able to report back to the primary care providers, the GPs. And she also offers some of the face-to-face appointments for those who might be attending clinics and require that support in terms of disease and education. In all this, it's very important for us to think about patient voice and digital innovation. And I'm pleased to say that we have been working very closely with the Macular Society. We've worked very closely with Colin. We've worked very closely with Diana Nicholas. And the learning that we have had in all those encounters is the importance of engaging patients in co-designing our services. Digital technology, fascinating as it is, but it needs to be communicated to the service users. We need to learn from you how to make these pathways better. So developing of digital pathways for different population groups, it requires a lot of input from our patients, from members of the society, and also from patient societies. We've seen the integral role of patient-public involvement. We've also seen the importance of us working collectively with our primary care colleagues, your GPs, your optometrists, your retinal screeners in the community. We have been doing such an amazing job, sterling job, ensuring that communication gets to all parties. There are multiple opportunities for patients living with diabetes. For example, community monitoring through the diabetic retinopathy screening services, which evidence and literature show that blind registration in England is come down for people with diabetes because of screening. So screening is part of the recommendation as part of the National SEPS Framework 2003. Patients with type 1 and type 2 are offered an annual eye screening where you get photographs of the back of the eye, and screeners are able to identify whether there's any sight-threatening disease or not. And you get onward referral if there's a need for early intervention. So managing patient expectation is important, and how we go about it is through engaging, is through involving our patients. There's also something about patient population groups and the use of technology. And my colleagues are working very hard from the research side to try to adapt all those things to ensure that we get a clear understanding of patient perception of digital technology. But there's also recognition that diabetes as a multi-system disease, it affects different parts of the body as it progresses. So we realize that our patients, we're fully aware that they might have multiple hospital appointments. They may be struggling between an appointment with an eye clinic and also, for example, an appointment with a renal clinic. So all those things would help if that technology is coming into place to answer those questions. At Moorfields, I'm pleased to say that we've introduced a patient involvement champion who is helping to steer patient public involvement in the medical retina service. So in October last year, as I said, we've been working with the Macular Society closely. On the 20th of October, we held one of our first virtual patient focus group, and we wanted to understand the use of digital technology and patient voice, patient population group and use of technology. This meeting was facilitated virtually through our colleagues from the Macular Society and us. And we had a very clear understanding of areas of improvement and the expectation of patients working with us in challenging times like this. I know this talk is more centric or fixated on diabetic macular edema and diabetic eye disease, but I just also want to share that innovatively, we are also working towards e-brochures for diabetic macular edema. So on this slide, it's an example of an e-brochure for age-related macular degeneration, which is available online. And the e-brochure has got two options: a very interactive 30 minutes, accessible in different language to empower our patients. Then there's the educational experience of the interactive, accessible and multilingual education to empower a patient to become patient citizens, peer review. Why I've put this AMD as an example, we are also thinking of an e-brochure for diabetic macular edema, diabetic eye disease, which is going to be practically led by experts, patients, and some of the community members. And in doing this, we're going to use an approach of having multilingual options in key languages, Swahili, for example, in Somali, Hindu, all those different languages, so that we can also support those who might have health literacy issues in understanding certain information that is given to them. We're also working very hard to see how we can launch the e-brochure for diabetic eye disease in the next coming months. The challenges and lessons that we've learned so far, COVID-19 fears affecting clinical attendance, the fear of public transport and the pandemic. We also know that human interactions versus digital innovation is quite a complexity issues when most of our patients have been used to be seen on a face-to-face basis. Management of those patients who might not be able to attend their hospital appointments is getting quite challenging, especially where there's a backlog. So in the future, these are some of the innovations that I think will be taking center stage, referral refinement, trying to come up with innovations such as digital consenting, consenting patients remotely, giving them information before they come to the eye clinic department, upskilling of nurses and allied healthcare professionals in the injection service. So I'm pleased to say that when you show up in our retinal therapy, in our injection clinic or injection service, it's a very multidisciplinary led. We've got doctors, we've got optometrists, we've got nurses, and most of the injections are administered by trained nurse practitioners. And we are almost very happy to support each and every session. So empowering our patients during and post-COVID is come up with several ways. Empowering patients with the use of gadgets or monitoring tools, and also telephone consultation advice support. So I would like to thank my colleagues in the medical retina department and also management for their support, and patient societies such as the Macular Society that we have worked with very closely. So in predicting the future, prediction is very difficult, especially about the future. The best way to predict the future is to invent it. Thank you for your attention.
Brilliant. Thanks ever so much, Adam. That was interesting. It's obviously about more fields, but I know that lots of other hospitals around the country are having similar thoughts, and everyone's working together to make the patient journey or pathways a lot more clear and modern, which is great. Speaking as somebody that's been going to eye clinics for the majority of my life, so that's brilliant. So thanks. As I said before at the beginning, I really want to thank Adam and Mr. Rajendran for joining us again, because we had some technical issues with the actual recording the first time round. So thank you both for finding some time. I would like to say that this goes along with our usual series of virtual clinics, and there's lots more on the YouTube channel, the Macular Society YouTube channel. So why not have a look at some of the past previous events that we've done? So just leaves me to say thank you to Adam and Mr. Rajendran. So thanks very much and goodbye.